colleagues, welcome back to my channel. Today I'm going to discuss some important topics from infectious diseases part of Toronto Notes Pediatric Chapter 2025 edition. Okay, let's start. The first topic I'm going to cover right now is otitis media with effusion. As we already know, otitis media means inflammation in the middle ear, and with effusion means there is presence of fluid in the middle ear without signs and symptoms of ear infection. So, it just means to say that there is presence of fluid in the middle ear, but there are no signs and symptoms of infection. Okay, now is the most common cause of conductive hearing loss. Yeah, otitis media causes conductive hearing loss as a complication, and otitis media with effusion also causes conductive hearing loss. 90% of the cases resolve themselves by 3 months. Okay, 80 to 90% of all children have one episode before 6 years. This is so much common. And 30 to 40% affected children will experience recurrence is also common. First episodes are also common in children. Okay, risk factors, they are saying the same as acute otitis media. Guys, remember from my last lecture, we read a number of risk factors of acute otitis media, which included genetic factors, the family history, the bottle feeding. The breastfeeding is a protective mechanism, and bottle feeding is the risk factor. And bottle feeding, especially in the lying down position. Also, there were some other risk factors like eustachian tube dysfunctioning, some infections, okay, and the barotrauma can also be the reason. Okay, so I want you to look at this again if I'm missing anything out. So yeah, eustachian tube dysfunction, infections, okay, cleft palate can also be the cause. Some syndromes like Cartagena syndrome and cystic fibrosis can also be the cause. Okay, and then immunosuppression or deficiency, or certain chemotherapy people who are immunosuppressed, like they're receiving chemotherapy, steroids, or they have diabetes. These are all the risk factors for acute otitis media or otitis media with effusion. Both are same. Okay, now come towards the clinical features of otitis media with effusion. It's basically the otitis media with effusion presents with fluctuating conductive hearing loss. So there is conductive hearing loss, but is fluctuating. Okay, it comes and goes. Along with this, there may be or may not be tinnitus. And tinnitus simply means ringing in the ear. There will be fullness in the ear, and there can be balance problems. As we already know, the inner ear is also associated with balance and hearing both. So hearing is affected, sometimes balance can be affected too. There will be conductive hearing loss, there will be fullness in the ear, there may be some degree of pain, and also there can be low grade fever. Okay, and the otoscopy findings are definitely very important, because in this way we have to differentiate it from just acute otitis media. Okay, so here, as we remember, the otoscopy of acute otitis media presents with a reddish tympanic membrane, and there is bulging of the tympanic membrane, and as a complication there can be the perforation or maybe a discharge coming from the ear from the tympanic membrane. Now, in the case of otitis media with effusion, in short, OME, otitis media with effusion, OME, that presents with a tympanic membrane that is discolored, either amber colored or dull gray. It is not reddish. If it is reddish, it's just acute otitis media. If it's not reddish, it means it's not inflamed. It's just discolored, either dull green color or amber color. Meniscus fluid level behind the tympanic membrane. Okay, so we can see fluid behind the tympanic membrane. Also, there can be formation of air bubbles. There can be bubbles on the tympanic membrane and retraction pockets, or it's also called tympanic membrane atelectasis. Okay, there can be retraction pockets or tympanic membrane atelectasis, or also there can be a flat tympanogram. Most reliable finding with pneumatic otoscopy is immobility. Okay, so the important thing that we need to remember whenever a scenario is given, a child presents to us with conductive hearing loss on and off, ringing in the ear, maybe sometimes pain. On examination of tympanic membrane, it's amber colored, and there is a fluid level behind the tympanic membrane, and also the tympanic membrane seems to be immobile on pneumatic otoscopy. So what is the diagnosis? Yes, you're right. The diagnosis is basically otitis media with effusion. Okay, now the management is expectant management appropriate if low risk for speech or language or learning difficulties. Okay, because if a child cannot hear, how can he speak? So therefore these children can present with speech problems, language problems, and learning difficulties. ENT referrals if unilateral otitis media before 6 months. Okay, if a child is less than 6 months and has one-sided otitis media with effusion, either he has bilateral otitis media with and age is more than 3 months, along with hearing loss, or structural tympanic membrane damage. Also we can see that there is some abnormality, anatomical abnormality of the tympanic membrane. So what we have to do, we have to refer the child to the ENT. So we need to remember, refer in what cases: if there is otitis media with effusion of very young age, less than 6 months in one ear, or is in both ears and the age is just more than 3 months, and also along with this is anatomical abnormality of the tympanic membrane. So we have to refer to whom? ENT. Okay, next thing, consider early ENT referral for children with craniofacial abnormalities or immunodeficiency. Also, the surgical options include meningotomy. Meningotomy is basically we are going to do something with the tympanic membrane by placing some tubes called ventilation tubes or tympanostomy tubes. Okay, we are making a hole in the tympanic membrane and we are putting certain tubes in the tympanic membrane. These are called ventilation tubes or tympanostomy tubes. Along with that, we have to do adenoidectomy if the tonsils are enlarged, if adenoids are enlarged, or on insertion of second set of tubes after first set falls off. Okay, so we are doing this placement of tubes for the first time, and it falls off after some time. This is also called a grommet insertion. So after some time falls off, but we have to put it again. So then okay, so we are going to insert the tubes again for the second time. Okay, and no role for antibiotics, steroids, antihistamine. Definitely there is no role, because when surgery is needed, the definitive management if is needed, then we cannot opt for these things. Okay, no drugs are going to show an effect. Okay, the complications are basically hearing loss, as we already know. There may be speech delay, learning problems, there may be chronic mastoiditis. Okay, mastoid bone gets inflammation and called chronic mastoiditis. There may be ossicular necrosis or erosion. Sorry about that. Ossicular necrosis or erosion and cholesteatoma, especially when the retraction pockets involve pars flaccida. Cholesteatoma is again a pearly white substance present in the ear. This is basically because of recurrent otitis media, and there is basically formation of this thing called cholesteatoma. And so when retraction pockets which are formed involve some parts of the ear called pars flaccida. Okay, now the retraction of tympanic membrane can happen. Of course, there will be a retraction of tympanic membrane, as you can also see in otoscopy. Also, there can be atelectasis and ossicular fixation. Okay. Next thing we are going to read is pediatric some skin conditions. Okay. First one I can see here is erythema infectiosum, also called the fifth disease, or the slap cheek syndrome. Is caused by parvovirus B19. Low risk of transmission once symptomatic. Respiratory secretion, it is spread by either respiratory droplets or infected blood. There will be maculopapular lacy rash, and these bilateral cheeks are basically involved with circumoral sparing, means the mouth area is spared but the bilateral cheeks are basically involved. That's why it's called the slap cheek syndrome. Okay, sometimes it can also affect the trunk and extremities. Okay, only sometimes. Okay, but especially the feature is slap cheek. Okay, now what happens that associated features may be initial 7 to 10 days of illness and fever, rash may be warm, it is non-tender and itchy especially, and maybe gloves and sock syndrome, or can be associated with another complex called star complex. Sore throat, rash, and arthritis. Okay, sore throat, rash, and arthritis. Next thing is management is just supportive. Complication rash fades over days to week, may reappear a month later with sunlight, exercise, and transient. Okay, so these can be the complications. Okay, now the next thing is papular acrodermatitis, not very common, caused by Epstein-Barr and hepatitis B virus, and this presence on the face, cheeks, extensor surfaces, and spears trunk. Is a kind of a viral rash, may have lymphadenopathy. It can be a viral, this kind of viral rash may have lymphadenopathy, supportive pain control. Hand, foot, and mouth. This is important. This is caused by Coxsackie group of viruses. Coxsackie group of viruses. Okay, and symptoms can be direct and contact with infected body fluids. And basically is spread by infected body fluids, either by direct or indirect contact. Okay, now the vesicles and pustules are made, and they are almost present on erythematous base distribution. Mouth, buttocks, all these areas are involved, basically hand, foot, and mouth. Along with that there will be mouth, buttocks, and acral area can also be involved. Okay, erythemas or exanthems or vesicles are formed, basically supportive management is there. Again, supportive management. Okay, herpes simplex caused by herpes simplex virus 1 2. Okay, so transmission is by saliva or birth, at birth, or sexual contact, and the grouped vesicles are present on a reddish erythematous base. And again, herpes simplex is basically treated as a merely supportive management, or consider oral or topical antivirals sometimes. Okay, that's considered. Okay, now next thing is Kawasaki disease, caused by it's not caused by anything. It's a different condition that we can read in some other chapter. And the next rash is measles. Okay, measles is basically what happens that caused by morbillivirus, and what happens is with the matters maybe maculopapular rash. Okay, and starts at the hairline and spreads downwards. There will be cough coryza conjunctivitis, 3 C's, cough coryza conjunctivitis. Okay, and there will be complex spots are there. Cough coryza conjunctivitis is there. Complex spots are present 1 to 2 days before rash, and then supportive management is needed. Basically, unimmunized contacts, measles vaccine within 72 hours of exposure, and respiratory isolation and report to public health. Okay, secondary bacterial infections can be there as a complication. Okay, then we have to read about non-specific enteroviral. Maybe enteroviruses can cause this type of rash. Then roseola basically caused by human herpes virus type 6. Okay, and saliva and perinatal transmission, and then there can be transplacental infection and genital cell integration. Okay, roseola is high grade fever, common irritability is common, loss of appetite is common, lymphadenopathy is common. Also, there can be high grade fever for a duration of 3 to 5 days, maybe irritability, especially The patient shows extreme irritability, loss of appetite. There may be lymph nodes enlargement. There may be erythematous or reddish tympanic membrane. There may be Nagyama spots, that is erythematous papules on soft palate and uvula. Nagyama spots, which are basically, what are Nagyama spots? Nagyama spots are erythematous papules on soft palate and uvula. So Nagyama spots are basically present on soft palate and uvula. Okay, less common cough, coryza. Okay, supportive management again there. Now the rubella is caused by ruby virus. Ruby virus. So Zeola is caused by human herpes virus. And rubella is caused by ruby virus. Okay, appearance will be again pink maculopapular, pink or maculopapular. Timing is basically 1 to 5 days after start of symptoms. Distribution starts on face and spreads to neck and trunk. Okay, so basically starts from the face and from there it spreads to neck and trunk. There may be a stark complex formation, there may be sore throat, arthritis, and rash. Supportive management is their report to public health. Prevention is by MMR vaccine. Excellent prognosis with acquired disease. Arthritis may last for weeks. Encephalitis is there. Okay. Now, the next thing I'm going to read is scarlet fever, that is caused by Streptococcus bacteria, and is not here. Okay, scarlet fever is present on some other page. Okay, then the varicella is caused with the varicella zoster virus. Okay, and the appearance is basically in the form of group of skin lesions, polymorphic macules, papules to crust formation, and there can be itching, malaise, fever, vesicular lesions become ulceration and ulcerate. So basically what happens, that supportive management is there. Avoid salicylated to risk of rice syndrome. Okay, consider antivirals, especially and contact isolation, and report to public health. Okay, so it's again a reportable condition. Next thing we are going to read right now is the third topic. First we read radius media with diffusion, then we read some viral rashes. Bacterial rashes means rash, and then the third topic I'm going to cover is infectious mononucleosis. This is basically a systemic viral infection that is caused by Epstein-Barr virus, and is multi-visceral involvement called the great imitator. Okay, so basically it's a viral infection caused by Epstein-Barr virus. The incidence is between 15 to 19 years, so it means it's more common in adolescents. Okay, and the 50% of children in developed countries, they have a primary Epstein-Barr virus infection by the age of 5 years, but less than 10% of children, they develop clinical infection. Okay, etiology is caused by Epstein-Barr virus. Transmission is mainly through infected saliva. That's why it's called kissing disease. And the other common cause, the less common cause is sexual activity. But the incubation period is just 1 to 2 months. Risk factors include infectious contacts, means people who are infectious, they can spread the disease from one to another. The people who are sexually active and multiple partners. Okay. Now, the history includes 2 to 3 days of malaise, and there will be loss of appetite. Okay, infants and young children, they often are asymptomatic or they present with mild disease. Older children, they can present with malaise, fatigue, fever, sore throat, abdominal pain, headache, and myalgia. So there may be malaise, there may be fever, fatigue, sore throat, abdominal pain, headache, and myalgia. The classic triad includes basically febrile, generalized, non-tender lymphadenopathy, and pharyngitis or tonsillitis. So there may be fever, there may be non-tender lymphadenopathy, there may be pharyngitis or tonsillitis, exudative in nature. Also, as is lymphadenopathy is there, fever is there, maybe inflammation of pharynx, and as well as the inflammation of tonsils can be there. Also, there can be involvement of liver and spleen leading to hepatosplenomegaly. Also, there can be periorbital edema. So, there may be swelling of eyes, and there can be a rash. Rash may be urticarial, maculopapular, petechial rash, more common after inappropriate treatment with beta-lactam antibiotics. Itis includes basically arthritis, inflammation of the joint, inflammation of the liver, inflammation of the kidneys, inflammation of the heart, brain inflammation, encephalitis. So all the itis are basically associated with infectious mononucleosis. I can summarize what I have read up till now, that Epstein-Barr virus is a causative agent for infectious mononucleosis. Incidence is in adolescent age between 15 to 19 years, very common, and it can be spread by direct contact with the infectious person, and can also spread by saliva, as well as less common sexual activity. Okay, and then what happens that if it happens in infants and very young children, either they remain asymptomatic or milder form of the disease. Sorry. But the older children, they may present with malaise, fatigue, fever, maybe sore throat and tummy pain. Okay, the triad of this condition is basically three main things: maybe fever, lymphadenopathy, which is non-tender. Always remember, in infectious mononucleosis, it is not tender. So, non-tender lymphadenopathy will be there, fever will be there, and also there can be itis things like tonsillitis, pharyngitis, etc. Also, there can be involvement of liver and spleen causing hepatosplenomegaly. There can be swelling of eyelid called periorbital edema, and there can be a skin rash. Okay, and itis are basically, there can be involvement of the liver, hepatitis, meningitis, encephalitis. There may be inflammation of joints called arthritis. There may be hepatitis, nephritis, inflammation of kidneys. There can be myocarditis and meningitis, and so all the itis are there in case of infectious mononucleosis. What are the investigations we need to do for diagnosis of this condition? A very important test is called the heterophily antibody test, also called the monospot test. Always remember this name. So, the diagnostic test, also called the monospot test, is very important because okay, this monospot test is especially sensitive in case of adults and older children, but is only 50% sensitive if age. Okay, the false positive results, they can occur with certain conditions like HIV, SLE, lymphoma, rubella, and parvovirus. Okay, Epstein-Barr virus titers. If negative heterophily test or the clinical suspicion remains high, then we have to do the titer. So first test, the first diagnostic test here is the monospot test. Okay. Sorry. So the first test here is the monospot test, but if it's a negative heterophily test or the monospot test, then we have to do Epstein-Barr virus titers. Titers are basically on the second line. Okay. Now, some common tests like complete blood count, differential blood count, blood smear. There may be lymphocytes, increased lymphocytes, lymphocytosis can be there. One special cells, some special cells like downy cells. There may be anemia. There will be low platelet count. All these things can be seen in the blood picture. Throat culture to rule out streptococcal pharyngitis. Alright, now the management. Management is always supportive. Okay, so supportive management is for infectious mononucleosis. There will be adequate rest is needed, hydration is needed, saline gargles are needed, analgesics are needed for sore throat. There will be rest, hydration, adequate fluid intake, saline gargles are needed, and analgesic painkillers are needed for case of sore throat. Splenic enlargement is often not clinically apparent, so all patients should avoid contact sport for 6 to 8 weeks. This is a very important concept that is basically that the MCQ came in many Q banks like this, that if a child is suffering from infectious mononucleosis, what advice we can give to the child. So as there is a chance of splenic enlargement in a case of infectious mononucleosis, although it cannot be clinically apparent, but it's advisable that all the children suffering from infectious mononucleosis should avoid contact sports for at least 6 to 8 weeks because there is a risk of splenic rupture. Okay, if the airway obstruction is secondary to nodal or tonsillar enlargement is present, admit for observation. If there is a lymph nodes involvement, enlargement of lymph nodes, as well as there is a tonsillar enlargement, we have to admit for observation and basically consider steroid therapy. We have to admit for observation, we have to admit for vitals observation, and also can think about steroid therapy. Sorry. Prognosis. Most acute symptoms resolve in basically 1 to 2 weeks, though fatigue may last for months even. Short-term complications, splenic rupture can be there. Okay, one important thing is Guillain-Barré syndrome can be a complication of infectious mononucleosis. Also, there can be pharyngitis and tonsillitis. Okay, next topic I'm going to cover right now is pharyngitis. In pharyngitis, as we already know, as the name indicates, is basically inflammation of the pharynx, okay, especially the tonsils, if present, causing a sore throat. Okay, so inflammation of the pharynx. Pharynx is basically a structure in upper airway, and also the tonsils involvement as well, and lead to basically what, sore throat. So the viral causes are the most common. 80% of the cases are viral, and the viruses are adenoviruses, enteroviruses, upper respiratory tract viruses, the COVID-19, even the Coxsackie virus. Okay. Now the bacterial cause is 20% of the cases, mainly group A Streptococcus, Mycoplasma pneumoniae, Neisseria gonorrhoeae sexually active, Clostridium difficile, and in the case of fungal, Candida. Okay, so all these are the, so viral, I'll just remember the viral causes are the most common, then comes the bacterial, and rare is the fungal. So the virus, most common viruses include adenovirus, Coxsackie virus, enterovirus, Epstein-Barr virus, and cytomegalovirus, and COVID-19. Okay, now we have to say that the group A Streptococcus pharyngitis is more common in winter or early spring, and the viral can happen all year long. Okay, and age group is basically 5 to 12 years, uncommon less than 3 years. So if a child is less than 3 years, we are not suspecting pharyngitis because it's uncommon, more common in 5 to 12 years of age. Okay, what is the presentation of pharyngitis? Pharyngitis group A Streptococcus pharyngitis include basically sore throat. There may be fever, malaise, headache. There may be nausea, vomiting, tummy pain, absence of other upper respiratory tract infection symptoms. There may be pharyngeal or tonsillar erythema, redness and exudates, enlarged and tender anterior cervical lymph nodes, palatal petechiae, strawberry tongue, and scarlet-like rash. Okay, these are all basically features of scarlet fever as well, because this scarlet fever is also caused by bacteria, similar bacteria. So basically there can be rash as well, there may be inflammation of lymph nodes as well, tonsillar enlargement as well, there may be strawberry tongue, and some systemic features like headache, nausea, vomiting, diarrhea, not diarrhea especially, nausea, vomiting, and tummy pain. Okay, now the viral, what are the symptoms of virus? So for viral, there can be just mild sore throat. There may be running. There may be some discharge coming from the eyes. There may be cough, rhinorrhea, runny nose. There may be hoarseness of voice, flu-like symptoms, fever, malaise, myalgia, arthralgia, and they may be absent or mild tonsillar exudates. They may be absent, either they're absent or they're mild tonsillar exudates, and there is no significant or non-tender lymphadenopathy. Okay, so these are the then if such features happen, then it's basically a case of viral pharyngitis. Okay, now investigation. Centaur scores are used to predict if throat culture will be positive. Okay, Centaur criteria is basically help to predict if it's bacterial or viral. These systems have not been found to be sensitive or specific enough to diagnose group A streptococcus in children and adolescents with a sore throat. Suspected diagnosis of group A streptococcus pharyngitis should be confirmed with a rapid streptococcal antigen test. Okay, so group A streptococcus pharyngitis that can be confirmed with a rapid streptococcal antigen test, RAS, rapid streptococcal antigen test, rapid streptococcal antigen test, and a follow-up throat culture if the rapid test is negative. So what we have to do, we have a suspicion of group A streptococcal pharyngitis. What we have to do, we have to do a rapid streptococcal antigen test, okay, and then follow-up of throat culture if the test is negative. Okay, the management of this is basically that antibiotics are given for group A streptococcus or Streptococcus pyogenes. We have to give penicillin V or amoxicillin or erythromycin if this penicillin allergy. So either penicillin is given, amoxicillin is given, and if penicillin allergy, then what we have to give? Erythromycin is given for 10 days. Can prevent rheumatic fever. If given within 9 days of symptom, does not alter risk of post disease. Okay, so this antibiotic can also help in prevention of what? Rheumatic fever. Okay, if given within 9 days of onset of symptoms. Okay, supportive management is basically give adequate hydration, acetaminophen due to pain or fever, hydration of fluid intake, and basically there will be acetaminophen, a painkiller. So it's antipyretic, acetaminophen due to pain or fever. Follow up if uncomplicated course, no follow-up is needed or post-antibiotic throat cultures are needed. But prophylaxis is basically we have to do tonsillectomy for severe recurrent tonsillitis. For severe recurrent tonsillitis, we have to do tonsillectomy. Okay. Now the complications. Basically, the scarlet fever is a preventable condition along with antibiotics. Acute otitis media, inflammation of sinuses. There may be inflammation of cervical lymph nodes called cervical adenitis, there may be mastoiditis. There may be peritonsillar abscess or sepsis. Okay, so basically we have to give antibiotics so that we can basically prevent these complications, including otitis media and maybe sinusitis, inflammation of lymph nodes, mastoiditis. So therefore before we give antibiotics to prevent these complications. Also there can be complication like scarlet fever, rheumatic fever, post streptococcal glomerulonephritis, pediatric autoimmune. Pandas is basically, what does it say? Pediatric autoimmune neuropsychiatric disorder associated with gas. Okay, pandas, pediatric autoimmune neuropsychiatric. D for disorder, A for associated, S for group A streptococcus, group associated with streptococcus. Okay, now the finally we are going to read the fever that is called scarlet fever. That is a very important fever, and that is definitely caused by group A streptococcus. Okay, that is in the form of a diffuse erythematous reddish eruption, is a hypersensitivity reaction to exotoxin produced by Group A streptococcus. So now we know the group A streptococcus causes scarlet fever. Requires exposure to what? Streptococcus pyogenes. Streptococcus pyogenes can cause basically scarlet fever. There may be acute onset of fever, there may be sore throat and strawberry tongue, very important. So after pharyngitis, there will be development of rash, especially in the groin area, in the axilla, in the neck region, in the antecubital fossa. Okay, so within 24 hours what will happen? There will be a sandpaper like rash appearance. After that it will become generalized and there will be perioral sparing. It's not itchy, it's not painful, non-tender, non-pruritic rash will be there, and is also blanchable rash, not itchy, not painful, and there is basically sandpaper like rash, and perioral sparing will be there. Okay, rash fades after 3 to 4 days, and may be followed by desquamation. Rash basically fades after 3 to 4 days. 3 to 4 days after there will be rash disappearing. Okay, treatment is with again antibiotics like penicillin, amoxicillin, erythromycin if they are allergic to penicillin, amoxicillin for 10 days. Okay, now the next thing that can happen because of group A streptococcus infection is rheumatic fever. They are going to talk a bit about it. Okay, so it is an inflammatory disease due to antibody reactivity following group A streptococcus infection. Okay, and much more prevalent in developing nations. Okay, and the Jones criteria is basically the diagnostic criteria for rheumatic fever is the Jones criteria. It requires two major or one major and two minor symptoms plus evidence of preceding streptococcal infection. So the child was suffering from some streptococcal infection. Now he has developed a certain set of symptoms. So there is evidence of streptococcal infection. Now two major criteria is there, one major and two minor criteria is there. A history of scarlet fever. There may be group A streptococcus pharyngitis culture, positive rapid antigen detection test and ASOT. Okay. Okay, so if there's a past history, if there's pharyngitis and we did the rapid detection test for antigen and that became positive. Okay, all these things. Okay, major criteria and minor criteria. What is the major criteria? Okay, it may be carditis, inflammation of the heart, the coverings of the heart. There may be carditis, and there can be valvulitis, inflammation of valves of the heart, arthritis, inflammation of joints. CNS involvement is Sydenham chorea, specific movements of the hands, and this is called Sydenham chorea. And then subcutaneous nodules below the skin can be present. So, Sydenham chorea, subcutaneous nodules, and one more skin thing called erythema marginatum. So, these are all the features of major criteria. Major criteria includes basic involvement of heart, inflammation, involvement of joints, heart, joints, and skin. Heart, joint, brain, and skin. Heart there may be valvulitis and carditis. Heart, there may be involvement of skin, which includes subcutaneous nodules. And the second thing is erythema marginatum, subcutaneous nodules below the skin, and erythema marginatum. And there may be involvement of the brain called Sydenham chorea. Sydenham chorea. Minor criteria includes basically arthralgia. So the minor criteria, there will be pain in the joint called arthralgia. There may be fever. There may be raised ESR or CRP, and there will be a prolonged PR interval. Okay, so there may be major criteria that involve various organs like heart. There may be involvement of the brain. There will be involvement of the skin, and also there will be from involvement of joints. But the minor criteria, just pain and fever is there. Some blood markers are increased like ESR and CRP increase, and also in ECG there will be prolonged PR interval. Okay. Okay, after this major and minor criteria, if either two major is there or one major and two minor is there, then and evidence of streptococcal infection, then definitely we make the diagnosis of rheumatic fever. Okay, and now the treatment is basically penicillin is given, erythromycin is given for acute course, for especially for 10 days, and prednisolone is given if there is severe carditis. Secondary treatment is basically prophylaxis with the daily penicillin or erythromycin. So prophylaxis is sometimes we have to give daily penicillin or erythromycin. Now the complications of this condition is basically myocarditis will be there, conduction system may be, there may be tachycardia, atrial fibrillation, valvulitis, pericarditis, chronic valvular heart disease can happen, infectious endocarditis can happen, and so there may be acute complication, involvement of the heart is there. There will be myocarditis, there will be tachycardia, atrial fibrillation, valvulitis, pericarditis, myocarditis, pericarditis, endocarditis, all those things, and atrial fibrillation. And then the chronic complications include basic involvement of the heart, there will be valvular heart disease, and infectious endocarditis, and thromboembolic phenomena. Okay, Onset of symptoms usually after 10 to 20 year latency. Okay, now here we can see a centaur criteria that is very very important for possibility of streptococcal pharyngitis. Either we have to give antibiotics or not in the case of pharyngitis. For patient presenting with sore throat or pharyngitis must be more than 3 years of age. If there is no cough, centaur criteria is basically the whole centaur is a mnemonic, and what we say that if it's seen in a child more than 3 years of age, if there is no cough, a C for cough. So if there is no cough, we give 1 point. Okay, if there is no cough, we give 1 point. If there is exudate or swelling, then we give 1 point. If there is nodes involvement, cervical lymphadenopathy, 1 point. If there is temperature, fever or more than 38 degrees C, 1 point. If there is a young person less than 15-year-old, we give 1 point. Okay, so centaur, CENTO, only young means age less than 15. We give 1 point, and all is rarely elder. Patient is more than 45, then we give again -1, means 1 point again, but is less. Okay, so basically what we have to see that, so all these criteria plus 1 plus 1 we have to calculate, and then we see his young age, then we give +1, but is elderly, then we give -1. Okay, now we have to check the we have to calculate if the central criteria appears to be 0, no further testing antibiotics are needed. If it's 1, 2, 3, then we have to do the rapid step testing or culture. So what we have to do, rapid streptococcal testing and culture. Okay, if 0, then we don't need any antibiotics or testing. Okay, if it's 1, 2, 3, we have to do rapid streptococcal testing or culture. If it's more than 4 equal to 4, consider rapid streptococcal testing and culture. Empirical antibiotics dependent upon the scenario. Next important thing I'm going to cover right now is post-streptococcal glomerulonephritis. That is again caused by group A streptococcus, and there will be information or involvement of basically kidneys. Okay, so there will be involvement of the kidneys, and there will be diffuse proliferative glomerulonephritis. Okay, and the clinical features are maybe asymptomatic, microscopic and macroscopic hematuria, cola colored urine can happen. As the kidneys involvement is there, so there may be either microscopic hematuria, macroscopic hematuria, or there may be kidneys involvement. So all features of nephritic syndrome. Diagnosed upon clinical findings of nephritis and recent infection, confirmed with elevated serum antibody titers against streptococcal antigens like ASO titer, anti-DNase. Okay, low serum complement, low C3, and increased ASOT anti-DNase. Now the management of this condition involves basically symptomatic fluid and sodium restriction, loop diuretics for hypertension and edema. So either there may be fluid restriction is the management, and sodium restriction, and then loop diuretics are given for hypertension and edema. In severe cases require dialysis if renal function is impaired. Okay, now treatment with antibiotic like penicillin, erythromycin if evidence of persistent group A streptococcal infection. If there is allergy to penicillin, then we have to give erythromycin. 95% of children recover completely within 1 to 2 weeks. 5-10% have persistent hematuria. Okay, so this is the last topic for today, and in our next session I'm going to discuss with you guys a very important topic called meningitis. Okay, and see you soon guys with the next session. I'm signing off for now. Bye guys, have a nice day, take care.